my topic for today is optimizing hypothyroidism, the role of patient-specific dosing, and basically focusing on pregnancy and hypothyroidism. Hypothyroidism in India is more compared to the Western countries. It is 3 times more common in women, and 1 out of every 10 pregnant patient is affected by hypothyroidism. We all know what is subclinical hypothyroidism. When the TSH levels are raised, but the accompanying T3, T4, free T3 and free T4 concentrations are within range. Now, I think all of us know we don't get free T3, T4, we get total T3 and T4. Depending upon the TSH levels, it could be mild when it is from 4.5 to 10, and more than 10, it is markedly increased. There are 2 types of hypothyroidism, subclinical and overt. And as the name suggests, subclinical is when the patient is totally asymptomatic. The TSH is from 4.5 to 10 and the FT4 levels are normal. Overt, as the name signifies, there are clinical symptoms of fatigue, weight gain, depression, constipation. Here too the FT4 levels are normal, but the TSH levels are more than 10. So let's talk about pregnancy and hypothyroidism. What is the prevalence? It is actually quite common, from 3.4 to 32.5% in pregnant women. Does subclinical hypothyroidism progress to overt? It does, depending upon the TSH levels and the TPO levels. So if the TSH levels are more than 10 and the TPO levels are more than, that is antibodies are more than 50 units, then the progression within 1 year from subclinical hypothyroidism to overt is 26, and within 5 years it is up to 30%. On the other hand, if the TSH levels are less than 10 and the TPO levels are less than 50, then the progression is just 13 to 15%. How many of you are getting your TPO antibodies done for all patients with hypothyroidism? Well, ideally this PPT presentation says yes, it should be done, and I'll tell you why. So how do you diagnose? We all know that the TSH levels are trimester specific. As per the Indian Thyroid Society guideline 2012, it is 2.5 for the first, the cutoff, and 3 for second and third. So what is the consensus statement of the Indian Thyroid Society? Trimester specific thyroid hormones reference should be established locally because of the variation in ethnicity, the maternal iodine status, the various assay methods. If the local ranges are unavailable, use an upper TSH level of 4 in late first trimester, gradually aligning with the non-pregnant ranges in the second and the third trimester. If the TSH concentration is outside the pregnancy reference range, so when the patient comes to you for the first counseling, what we write is just TSH. Now if this TSH is high, then you get the T4 levels estimated to confirm the diagnosis. In case of non-availability of reliable FT4 assays, which is almost I think at least our state, multiply T4, which is what you generally get, by 1.5, and that is then taken for comparison. For screening for thyroid antibodies, like I asked everyone, some get it done, some don't get it done. In women with known thyroid autoimmunity, the TSH concentration should be assessed every 4 weeks till mid-pregnancy, that will be around 24 weeks of pregnancy. TPO-AB status should be assessed in pregnant women with a TSH concentration anything more than 2.5. Why? Because the prevalence of thyroid peroxidase antibodies or thyroglobulin antibodies is positive up to 18%, and Indian epidemiological studies have shown the presence of positive TPO antibodies in up to 40% of hypothyroid pregnant women. So should we get it done now? The implication becomes then how you treat such patients. Now, so what is the impact of hypothyroidism in pregnancy? The risks with subclinical hypothyroidism and why it should be managed. There is 3 times more incidence of complications by placental abruption, 2 times risk of preterm birth. The rate of miscarriages is 6% compared to 3.6 in euthyroid women, and 2 to 3 times more risk of pregnancy-related complications in women who are untreated and they have subclinical hypothyroidism. So just a little more detail, we've already covered pregnancy losses and abortions and miscarriages and preterm delivery. There is also increased probability of GDM, postpartum and antepartum hemorrhage and PIH. What about the offspring? Does it trouble the baby also? Yes, it does. There is increased incidence of IUGR, preterm birth. So when the baby is IUGR, there's going to be low birth weight, poor Apgar score, respiratory distress syndrome. I had little queries about the neurodevelopmental disorders. I did look up the net and was not very satisfied whether I should read this line or not, so I'm skipping it. But yes, there is some correlation with occurrence of metabolic syndrome in this baby in youth. So what are the challenges in the current approach of management of hypothyroidism in pregnancy? Why are we talking about it again and again? Because sometimes hypothyroidism is a lifelong disorder. Once it is diagnosed, the lady doesn't remain on 25 or 50 units of L-toxin or L-thyroxine throughout her life. In pregnancy, things change. FT3 and FT4 levels will gradually decrease from the first trimester to the third, indicating increased demand for thyroid hormones by both the fetus as well as the mother throughout the course of pregnancy. That is why a regular monitoring of TSH and free T4 levels are needed throughout pregnancy. Plus, pregnancy we know is a dynamic process. There is a lot of physiological changes. So because of the changes which occur in pregnancy as a normal thing, the absorption, the distribution, metabolism and the excretion of the drug keeps getting altered. There is delayed gastric emptying time. We know that because of the progesterone hormones and the gravid uterus. Increase in the gastric pH, it alters the drug bioavailability. There is increased cardiac output, which leads to increased hepatic blood flow, so increased elimination of some drugs. Increase in the total body water, we know that, increase in the ECF. So there is altered drug disposition. There is increase in the fat compartment. So there is decreased elimination of lipid-soluble drugs. Increase in the GFR, so increased renal clearance, decreased plasma albumin concentration, increased free fraction of drug, and alteration in the cytochrome P450 activity. So the oral bioavailability is affected. So all in all, because of the natural physiological changes in pregnancy, there is an alteration in the ADME of any drug. Besides all this, there is increased LT4 dose requirements due to larger physiological thyroid hormone demand. What is the impact of suboptimal and excessive treatment of LT4? We also sometimes end up overtreating, which is again harmful. Now, prevalence of undertreatment is common up to 55% compared to just 1% when there is overtreatment. Despite our repeated request, so many of the patients will not take thyroid medication क्योंकि एक बार खाएंगे तो जिंदगी भर खाना पड़ेगा. So the studies have indicated that only 50% of LT4 treated women will maintain high adherence during pregnancy. What does undertreatment lead to? We've already dealt with it: miscarriages, fetal growth restrictions. Overtreatment, yes, it happens. It also has its consequences. There is preeclampsia, preterm birth, and gestational hypertension. So there is a complex need for optimum treatment of hypothyroidism in females. What are the important influences on the dose requirement of L-thyroxine? L-thyroxine as hormone, unlike other drugs, do not work on a fixed dose regimen. It requires variable dosing adjustments throughout pregnancy sometimes, and then of course throughout her life. So what are the factors which will influence the dosage? The gender, the age, the body weight, the time of LT4 intake. Does she actually take the medicine empty stomach and wait for 20 minutes? Intake of food, thyroid remnant. What is actually the status of her thyroid? How much is it working? Are there any regulatory deficiencies? The equilibrium between FT3, FT4, are there some deficiency of the enzyme? The conversion efficiency, resistance to thyroid hormones, it could be a hereditary resistance syndrome. Disease etiology, higher dose requirement in these patients, those with thyroid cancer or because of deiodinase activities will lead to problems. Pregnancy, we know that throughout the pregnancy period, there will be increased demands. Any comorbidity, like gastrointestinal absorption of thyroid hormones, like celiac disease and all, that will hamper. Use of other drugs which may interfere with the absorption, and then of course adherence, which is still only 40%. So why the need for patient-specific dosing? Patient-specific dosing of L-thyroxine involves precise measurement and adjustment of doses to optimize the therapeutic outcome in patient with hypothyroidism. It addresses the LT4's variable bioavailability influenced by food, concomitant medications, and patient-specific factors. The initial assessment is done at the first meeting. along with the questionnaire as to whether she has any symptoms. Then the TSH and free T4 levels are assessed to assess the effectiveness of the current dose. Do we need to increase, or we need to keep it same, or we just reduce it? And then gradually adjusting the dose based upon the laboratory results and also clinical response. So how do you decide the dose? It can vary greatly. It may be based on the amount of residual thyroid function, the body weight or the lean body mass. It depends upon, so let's talk about patient-specific precision dosing for hypothyroidism in pregnancy. The treatment goal in the first trimester is to maintain TSH levels less than 2.5. The dose is increased empirically by 25 to 50% once the pregnancy is confirmed, and then it is further stabilized in the second and third trimester. How do you monitor? TSH levels are assessed every 4 to 6 weeks, repeating this again and again till mid-pregnancy. And once it is established by then only once at 30 weeks. If it has been recently diagnosed, suppose she was, now this is what I'm talking about, she already has hypothyroidism. In pregnancy, the dose is increased empirically by 25 to 50%, and then you keep checking the TSH levels every month or after every 6 weeks till 24 weeks. If she's been recently diagnosed, you start at 2 milligram per kg per day, 30% higher than the non-pregnant dose. Most women on LT4 pre-pregnancy need dosage increase. This is basically to reduce the adverse obstetric outcome. So, what is the treatment plan? Suppose the TSH levels are more than 10, you start with 50 micrograms of levothyroxine. If the dose is between 2.5 to 10, you start with 25 micrograms of levothyroxine. The cutoff is taken as 2.5 for the first trimester and 3 for second and third. If the levels are less than this, then no treatment is needed. You just continue with routine pregnancy care. I hope till now I am clear. More than 10, you give a 50. Less than 10, but more than 2.5, you start 25. Up to less than 2.5, first trimester, less than 3, second, third, you don't do anything. Now coming to the TPO antibody status, like Dr. Vandana just remarked, let us see what you have to say. So should we get it done or not? Now suppose a patient has a TSH levels of 10. You do her thyroid antibodies. Irrespective that they are positive or negative, you have to give her medication. If it is between 4 to 10 and she is positive, please give her. However, if it is negative, you may consider. If you think she is the kind who will be sincere, will come for a regular follow-up and she is asymptomatic, so that depends upon the bond you have with the patient, you may or may not consider it. If it is 2.5 to just 4, she still has raised TSH. If the levels are positive, again you may consider giving her or not giving her. I'll repeat this line again. So see, the point is, this, I read from where they've taken up this particular slide. It is by Foxy, ITS, everything. So that is why I was focusing on this. Every 4 weeks, that means every month, आप TSH कराते रहिएगा. नहीं, up to 2.5 to 4 होता है, you can consider. हाँ, आप consider कर सकते हो. Absolutely. You still get it done, whether she needs a follow-up forever or you need to stop 6 weeks postpartum. Yes. Yes, you don't stop. Absolutely. But if she's negative, you can give her a break. But in patients with BOH, we always get it done. Haan. But no, I'm not saying it causes that, but we always get it done irrespective. We are talking about a pregnant woman who is 2.5 to 4. Yes, it should be done. That is the guideline says, not our personal choice. So the consensus of the house is, irrespective of the guidelines, East Delhi Gynae Forum says, हम नहीं कराएंगे. No ma'am, I am just reading the guidelines. So 2.5 and 4, if it is positive, you can consider it. Otherwise, irrespective, anything more than 4, please give her medicine. So what is the treatment plan? If she is already undergoing treatment, you continue with the same dose and target range during pregnancy. Repeat after 6 weeks after starting the treatment and adjust the levels based on the TSH. Now suppose the levels were more than 2.5 in the first trimester and the current dose is 25. So this is, I'm talking about a patient who already has hypothyroidism or whatever, उसको आपने टेस्ट किया more than 2.5, you start her on, she was already on 25, then you make it 37.5. बट अगर फर्स्ट टाइम डायग्नोस हुआ है तो आप उसको 25 ही देंगे. यदि वो फर्स्ट ट्राइमेस्टर में आती है और उसकी करंट डोज 50 है, you make it to 75. If she's on 75, you make it to 112.5, and if she's on 100, you make it 150. So this is the increase you have to make for any patient who already has hypothyroidism and she's come to in the first trimester and the TSH levels are more than 2.5. This is how you increase the dosage from 25 to 37.5, from 50 to 75, 75 to 112 and 100 to 150. Yeah, 25 का 12 हो गया, 50 का 25 हो गया, 75 accordingly. And if she's come to you in the second or third trimester and if the TSH levels are more than 3, it is the same schedule from 25 to 37.5, 50 to 75, 75 to 112 and 100 to 150. So this is how you increase the dose in the subsequent trimesters, trying to keep the cutoff up to 2.5 or 3. So titration of the dosage postpartum. Once she delivers, reduce the dosage to the preconception dose. And the levels should be tested again after 6 weeks postpartum to assess the thyroid status. You have two choices. Once after 6 weeks, when she comes to you postpartum, the levels are normal. You can discontinue, especially if the dose was less than 50. But if she was beyond 100 or something, then you have to keep going. If the dose which you're giving was less than 50 and postpartum, the level has come down to normal, stop the medicine, repeat after 6 weeks, and if it remains same, it will be discontinued. Then ma'am, you have to keep giving. You have to continue, yes. But you have to continue that. Either you then discontinue altogether. She was taking less than 50 micrograms. Postpartum 6 weeks per normal. Again 6 weeks repeat normal. You can stop. Or you can do a gradual titration instead of an abrupt discontinuation. So you assessed her after 6 weeks. You reduce by 50%. Again after 6 weeks, and even till that time the patient remains euthyroid. Then you can consider a trial of stopping entirely. But you don't stop. You continue monitoring her. So that the patient remains euthyroid and avoid hypo or hyperthyroidism. Thank you.